Good afternoon, everyone, and to Dr. Mahathir. Today, I'll be presenting the topic of iron deficiency anemia for the subject of advanced hematology. Before that, let me introduce myself. My name is Nicholas Hulus, final year student for Bachelor in Biomedical Science. Background of this topic is that 1/3 of the world's population is reported to be anemic, with iron deficiency being the major cause. Anemia due to iron inadequacy in adolescents is linked to learning disabilities and aberrant conduct. It can also lead to restless legs syndrome, pica, and impaired growth and development. IDA affects 2 to 5% of postmenopausal women and men and can be life-threatening. IDA warrants immediate evaluation to determine the underlying cause, as well as assessment for iron intake and re-examining the patient's lifestyle. Iron is essential for several biological mechanisms, including respiration and energy generation. Excess iron can be harmful, so absorption is restricted. The majority of daily iron requirements is approximately 25 mg per day, are met by macrophages that recycle senescent erythrocyte. Figure 1 shows the macroscopic RBC morphology in iron deficiency anemia. There are various physiologic, environmental, pathologic, and genetic reasons of iron deficiency. Etiology may vary significantly or coexist in distinct patient demographics, such as children and the elderly. There are 3 types of IDA. First, absolute iron deficiency anemia is caused by a decrease in total iron storage in the body. It may arise in cases of high demand, reduced intake, and malabsorption, or persistent blood loss. Second type, that is functional or relative IDA, is a term used in the medical literature to describe 2 main situations. First, when iron is poorly mobilized from stores to the circulation and erythropoietic tissue, due to chronic inflammation and raised hepcidin levels. Second, elevated erythropoiesis is caused by an imbalance between iron demand and supply in the body. Third type is that IRDA is a rare autosomal recessive disorder characterized by a mutation in TMPRSS6 that results in high hepcidin levels. Patients with this condition are more resistant to oral iron supplementation as well as to ESA therapy. Figure 2 shows the diagram of various etiologies of iron deficiency anemia. The global incidence of iron deficiency without anemia remains mysterious. IDA has significant global medical and social consequences, including impairment of cognitive function in early children and negative pregnancy outcomes for both mothers and babies. It is difficult to separate the proportional role of iron deficiency and anemia. Iron is an important element whose levels are mostly determined by food intake, intestinal absorption, and recycling. There are 2 types of dietary iron, heme iron and non-heme iron. Heme iron is readily absorbable and is derived from hemoglobin and myoglobin in meat, poultry, and fish. The majority of non-heme iron is present in plant foods. However, it is not as easily absorbed. Compounds present in plants such as phytate, oxalate, polyphenols, and tannin impede the absorption of non-heme iron, as well as certain medications such as proton pump inhibitors. In contrast, ascorbic acid, citrate, and gastric acid promote the iron absorption. 5 to 15 milligrams of elemental iron and 1 to 5 milligrams of heme iron are consumed daily in a healthy diet, but only 1 to 2 milligrams is finally absorbed into the gut, primarily in the duodenum and proximal jejunum. Figure 3 shows the pathophysiology illustration of iron deficiency anemia. Patients with iron deficiency anemia might appear with symptoms consistent with all anemias, which are occasionally accompanied by specific IDA symptoms such as fatigue, headache, tachycardia, syncope. IDA affects epithelial cells with a quick turnover, resulting in dry and rough skin, dry and damaged hair, and mild alopecia. Figure 4 and 5 shows clinical presentation of chylosis and chylonychia in IDA patients. Every patient with IDA should have a celiac test and urinalysis to rule out hematuria. 1% of IDA is caused by a cancer of renal tract, such as renal cell carcinoma. IDA is difficult to diagnose, and many iron status measures appear to offer the most accurate evaluation of iron sufficiency. There is no consensus on the threshold, and there are differences among laboratories. Mean cell hemoglobin and volume are affordable, readily available, and sensitive measurements, but only become apparent in an extended period. Figure 6 shows the box of diagnostic tests for IDA. IDA has since been normally treated with 3 doses of ferrous sulfate per day. A daily dose of 15 to 20 mg of iron can be as beneficial as greater levels and are easily absorbed with less gastrointestinal side effects, according to a study published in the American Journal of Clinical Nutrition. A good starting point for oral iron replacement is a single dose of ferrous sulfate, given with a meal that comprises meat, if not vegetarian. Iron should be administered intravenously to any iron-deficient patient who does not respond to or cannot tolerate oral iron. Continual blood loss, such as that caused by inherited hemorrhagic telangiectasia, will necessitate iron infusions. Patients with a history of intestinal operations or bariatric surgery should also be given iron intravenously. Figure 7 shows the pathway of IDA treatment. Now, the permanent effort should be made to increase availability to and consumption of iron-rich foods as a prevention. Iron-rich meals should additionally contain iron absorption boosters such as ascorbic acid. Iron enrichment of food such as rice, maize flour, cornmeal is also performed in many countries in Asia, Africa, and Latin America, and is recommended by the WHO. Iron supplementation is recommended to prevent IDA in situations when the incidence of anemia is at least 40%, and the recommendations as shown on the slides. Iron supplements should be administered to babies and children in malaria-endemic regions in combination with public health interventions to prevent, diagnose, and treat malaria. Although iron supplementation can negate the protective effect of ID against malaria infection, it is of less concern in settings where preventative interventions are available. In the same context, iron supplementation is indicated for menstruation adult women and teenage girls. For those non-pregnant females in the reproductive age range, with 30 to 60 mg elemental iron daily tablets for 3 consecutive months each year. Figure 8 shows dietary recommendation for IDA prevention. This case study is presented with a healthy 57-year-old man with hemoglobin with 11.6 grams per deciliter. From this case study and literature reviews conducted by Venakota et al. In 2019, it was shown that acid suppressive therapies such as proton pump inhibitors with or without the addition of calcium carbonate are capable of inducing iron deficiency anemia with clinical significance. By decreasing stomach acidity, acid suppressive or acid neutralizing drugs likely produce an adverse environment for the absorption of non-heme iron. Intake of calcium carbonate can also limit iron absorption via many hypothesized processes. In animal investigation, calcium carbonate inhibited iron absorption through intestinal mucosal cells and lowered iron solubility in intestinal lumen. In advanced development, both thalassemia and iron deficiency anemia share key hematological features such as microcytic and hypochromic erythrocytes, making it difficult for doctors to utilize conventional blood analysis to differentiate between the two disorders. Although hemoglobin assay, DNA analysis, and ferritin tests are the essential assays for diagnostic testing of thalassemia and IDA, performing all these tests on every patient with microcytic anemia increases the financial burden for patients, particularly those from regions with limited access to health care, where these assays may not be commonly available. In order to improve the diagnostic testing and effectiveness of thalassemia and IDA, more reliable and cost-effective screening tests are required. Wong et al. Studies in 2021 reveals that the CellaVision Advanced RBC software is capable of distinguishing between thalassemia and IDA in normal blood smears. Although the morphological results may not be adequate to provide a definitive diagnosis, they constitute a reasonably easy and cost-effective screening strategy that will facilitate further diagnostic testing for thalassemia and IDA, hence enhancing diagnostic effectiveness. In conclusion, contrary to other prevalent anemias and hemoglobinopathies, IDA may be diagnosed or treated in the majority, if not all, persons. However, analysis of IDA must take into account the convergence of several causal variables. If resources are sufficient, personalized methods to therapy must be prioritized. In the impoverished world, more collaborative initiatives are being used to combat the overlapping causes of IDA, which affects hundreds of millions of people throughout the world. In the end, it is anticipated that increasing study and knowledge of iron biology will aid in the development of innovative solutions for the global eradication of this illness. And with that, I conclude my presentation today. I thank you to all who are listening to, and I say goodbye to you.